Thank you. So I'm Robert Boyle. I'm a reader in pediatric allergy at Imperial, and I'm going to talk to you about this topic of spotting fake science. And what this session is designed to do, and Nicola, will you tell me if my screen's not sharing properly?
That's perfect.
Great. So what this session is designed to do really is to help you see some common ways in which research findings, guidelines, and the information that is transmitted through us or in other ways to patients can get distorted. To understand how profound that impact can be on clinical practice and health outcomes, and to begin to develop skills to see through this sort of information and to work out what is reliable and what's less reliable in terms of the information that's thrown at you around health and clinical decision making. And as a way of background, this isn't a new issue. This is a 2009 report from the Institute of Medicine of the National Academies in USA, they, this had lots of leading editors and scientists on the report, and really recognizing the awkward relationship between commercial influences and science, and particularly science around health and healthcare. And the areas that it can get impacted, which we'll come back to during the session, are the integrity, reliability of scientific findings, what gets transmitted in medical education, and how reliable that is. Ultimately, the quality of clinical care and people's health. The patients tend to be the people who suffer when things go wrong in this regard, and people's trust. So a lot of the sort of commercial aspects can sometimes cloud what the scientific truths a bit in terms of with marketing messages, etc. And that makes it very confusing for people working in healthcare and for their patients and for general public in terms of, well, what's real, what's not, what can we really trust? Can we trust doctors anymore, etc. So that's kind of the backdrop. So the recognition that there's an issue there. What can we do about that? And really one of the main things we can do about that in medical education is to increase our awareness of the problem, recognize how profound and impactful it can be, and develop skills to try and sort the wheat from the chaff, so to speak, so that we can draw out the more reliable scientific findings, sources of medical education, patient care guidelines, etc., and not spend too much time listening to the siren voices calling for commercially important actions which aren't necessarily always to the benefit of patients. So sorry for the slightly long-winded introduction. BMJ have played quite a part. Most of the major medical journals have sort of recognised this an issue and have tried to advocate for change, largely unsuccessfully. So since 2009, not much has changed in terms of the sort of adverse impacts of commercial imperatives on or commercial incentives on health. So BMJ have been running a long campaign around overdiagnosis. So they see this is an end point sometimes of not enough distance between the evidence generation and guideline production, clinical practice, not setting enough distance between that activity and commerce, and you end up with this issue of excessive diagnoses, everyone having a label, and excessive treatment excess as well. And so BMJ have been trying to call for people to put forward proposals that might lead to a sort of cleaner distinction between the money makers and the sort of public healthcare providers and scientists. In general, these commercial, if you wanted to make money out of your product, you want to put lots of money into marketing, you want to kind of manipulate the science or manipulate the guidelines, etc., so you get maximum sales. You kind of want to work at the higher ends of the hierarchy of evidence. So guidelines, typically about 80% of guideline members for most guidelines have some sort of relevant conflict of interest related to that. So influencing guidelines either by commissioning them, supporting them indirectly, or supporting the individuals on guideline panels is big. Generating systematic reviews, people trust those. Trials, they're running trials, influencing trial reporting, etc. And then a little bit around expert opinions and patients. So we're going to touch on all of those areas, and I'm really going to give you 7 tricks of the trade, basically 7 tricks of the trade to try and make your product look much more exciting than it is, which we as healthcare professionals, I think most of the audience need to be aware of, and can be helped. And they're quite straightforward. Right? I'm just going to illustrate each one with an example, just to sort of demonstrate the issue. So the first question you should ask when you see a trial, we're going to start with trials and then move on to guidelines and other aspects. So trials really are the cornerstone of evidence. They drive a lot of our behavior, and certainly licensing of products and guidelines, etc. First question you need to ask yourself when you see the trial of an exciting new product is, what was it compared with? As the first trick of the trade, if you want to make your product look more exciting than it is to compare it with nothing. Even better, compare it to something that's maybe a bit harmful, something that, at the wrong dose, etc. So what was the comparator? And people so often ignore that. You see exciting new trial graphs of, improvements in disease severity, etc. What was it being compared with? And is the comparator something that you would normally use in current clinical practice? Is it the best? Because really, when a new drug comes along, and this example here is eczema, you've got these new drugs came along about 15, 20 years ago now, calcineurin inhibitors. We already had topical steroids for reducing inflammation in eczema. There's new anti-inflammatories, so are they any good? And as a clinician and a patient, what you really want to know is, well, is this any better than what we use at the moment, which is topical steroids? And you can look at what they've been compared with, and this is a couple of years old now, but it's a summary at that time of all the randomized controlled trials of topical treatments for eczema. Quite a lot of them, about 170, I think. And what this network shows you is what has been compared with what. And those new drugs we're talking about, tacrolimus and pimecrolimus, the calcineurin inhibitors, which came online around just after 2000, they should have been compared against topical steroids, right? Because you want to know, are they any safer? Are they any more effective? What's the sort of, do you get a faster response, more long-lasting response, better tolerance? And then factor in any cost differences, and you've got your kind of decision-making information. What you see, and then the best example here really is pimecrolimus or Elidel. So that pimecrolimus is compared with nothing, so the vehicle without the drug in it, in 25 different randomized controlled trials. So pimecrolimus, is it any better than nothing? 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 Right. So you do the question, how many times do you need to answer that very similar question? You can look in different populations, different age groups, perhaps different duration of treatment, but you kind of start to run out of important questions after you've done a few of those. How often has pimecrolimus been compared to, say, 1% hydrocortisone? Because pimecrolimus is not a sort of very strong treatment, so you might compare it to mild topical steroids. Very thin, one line there. It's only ever been compared to what you really want to know, which is mild topical steroids, once. So this is just, and this isn't the sort of outlier. I mean, this is sort of fairly typical in pharma, that most new products get compared with nothing. And manufacturers are typically quite reluctant to compare their products with existing effective treatments because it's risky. They might find there's a new safety signal with their new product compared to the other one, or it's not quite as effective, or the difference is rather small and it doesn't really justify the extra cost of the new product. So, to get licensed, you need to show that your product does something compared to nothing. Good comparison, nothing. But for clinical practice, for clinical decision makers, we really want to know how it measures up. So there's an active avoidance of active comparator studies. So you need to be aware of that when you look at new results for new treatment. And some of those pimecrolimus trials may have fallen into this category, which is called seeding trials. And again, I don't know, maybe we could try and make it a little bit more interactive. I don't know whether anyone wants to put anything in the chat. Does anyone come across seeding trials before? Everyone aware of what they are? Let's see if I can see the chat there. And okay, I guess given this is being recorded and I can't seem to get to the chat, we'll limit that.
There's no messages in the chat so far.
Yeah, okay, so maybe you haven't come across seeding trial. The seeding trial basically is a randomized controlled trial designed by the marketing department of a drug company, right? And we didn't really know about them until some legal cases and documents came out and go, oh, wow, my goodness, this is what's going on. And this is one of the classic ones, the STEPS trial. And they're designed by the marketing department. And they say, this is what we're going to do. We want our product to be used in, I don't know, China, right? It's already been licensed in in relevant areas. It's licensed in China, but we want people to really get excited about it. So what we're going to do is a multi-center randomized controlled trial of our product against nothing, and we'll get all the key opinion leaders in China on board. We'll invite them to some meetings, etc., pay for their travel or whatever, get them engaged with our company, and get them do the trial. And they'll use the product. They'll get used to it. They'll see how effective it is, and we know what the results are going to be more or less because it's going to be similar to the other trial. So with some of those pimecrolimus trials, the 25 randomized controlled trials against compared with vehicle may have been seeding trials, and they're generally not thought to be a very ethical use of science because you're doing randomized controlled trials. Often you're using publicly funded networks to facilitate those trials. You're using a lot of expertise and time, which scientific resources which could be better used somewhere else. And certainly we've had trials coming through our department here which for me look like pretty obvious seeding trials. There's no sort of new scientific information to be generated from them, but just testing a product against nothing. Again, that's already been well established to be better than nothing. So keep your eye out for those. And when you're asked to participate in a trial, ask your question, well, has this been done before? If so, and what's the added value of this particular trial? Is it really necessary to test it again in the same age group, just in a different region? Second question. Okay, so what do they compare their intervention to? The second question is, what do they measure at the end of the trial? And there's a mixture of things that you might measure at the end of the trial to see how effective your treatment is. So for eczema, there's actually an international core outcome set which has been developed over the last 12 years or so, which says these are the things that really matter to people with eczema and their carers and their clinicians, and should be measured in every single trial. So you won't be surprised to hear with eczema, it's things like symptoms. So eczema symptoms, itching, sleep disturbance, etc., and signs, and then perhaps quality of life and frequency of flares. So those sorts of things. In a trial where you're testing your new product and you're not really sure how effective it's going to turn out to be, you might choose some other outcomes to report. So typically there's sort of, in the marketing things you listen to, you'll see surrogate outcomes used a lot, or mechanistic outcomes. Look at the way that this product influences your dendritic cells in your Langerhans cells in your skin. Look at the way they deactivate them, and look at the T cell impact on T cells in vitro. Isn't that exciting? So those sorts of outcomes, which of course are important and relevant for science, but wouldn't necessarily be the sorts of things that should nudge clinical decision making, because your patients aren't really that interested in what's happening to their Langerhans cells. They want to know whether their symptoms are going to get better. So let's come to the one and only comparison of pimecrolimus against topical steroids. So this is the trial we really want to know about with this new product. How does it weigh up to topical steroids, which we've been using for decades? They're pretty effective, cheap as chips, pretty safe. People don't like them because you have to put them on. They don't cure anything. Sometimes they sting a bit. People worry about side effects, shiny skin or streaky red lines or something. How does pimecrolimus weigh up there, and what are we going to look at? Well, first of all, we might look at whether it's as effective for managing symptoms, and then we might look at safety. The manufacturers of pimecrolimus conducted the largest randomized controlled trial ever undertaken for eczema. So you need to know about this if you see kids with eczema, and I'm sure that you'll see kids with eczema. 2,400 infants, a 5-year duration trial. So infants with eczema enrolled, and they were randomized to either use this new thing, pimecrolimus, PIM, or topical steroids, so 1% hydrocortisone or similar. They would use them whenever they get symptoms, right, to be used as needed. Then, in fact, they could use them quite regularly, but in the pimecrolimus group, if the eczema gets really out of control, then you use steroids. In the steroid group, obviously, if the eczema gets out of control, you also use steroids. So they're randomized to have these treatments for over a 5-year period. The interesting thing is the outcome that they measured. So they measured as an outcome, and you'll see in the, sorry, I should go back to the yeah, here we are. So in the results, so they both worked okay. They're both, basically, and they're both the only real comparison between the two groups that they got into the abstract here is that with pimecrolimus, you had used less steroid than if you're randomized to steroid. Okay, everything else that's the only difference, and they've got that in here. Remember, this is all the top dermatologists around, and it's the largest eczema trial ever run, and this is the main finding in the results section, although the figure got pushed to the supplement. The median number of days when topical steroids were used. Topical steroids were used a lot in the group that were randomized to use topical steroids. Topical steroids weren't used very much in the group that got randomized to use something else. And that's what I would say that's a fairly classic spurious outcome. It's an outcome measure that is really not surprising. If you randomize people to drug A and drug B, and then you measure which group used drug A more, it wouldn't be at all surprising to find that the people who are randomized to use drug A more than the people who randomized to use drug B. But this has been spun. So what you'll see in this has got all the hallmarks of a sort of marketing department being involved in reporting of this trial, because it's it's funded by the company who make one of the products. It's got medical writers involved, professional medical writers, and then a lot of top names who probably contributed a smallish amount to actually the writing of the report. And so you've got this sort of strap line, which is, this is the key marketing message, that pimecrolimus was steroid sparing. And of course it was steroid sparing if you were randomized to this instead of steroid. But it's not really a valid research question, but it's a very useful marketing line. So that's the second point, really, is the outcome needs to be something that matters to patients, and something that's sort of valid. Really, this was actually all about safety. And it's quite interesting to look at the correspondence for this trial, because it took a lot of back and forth from various different correspondents to get the people to actually reveal that there wasn't a safety benefit to pimecrolimus. In fact, pimecrolimus was associated with increased various adverse effects compared to the steroid group. So the actual, the reason people might not want to use steroids and might want to use this instead is a safety concern, right? But actually the safety profile of the new drug was worse than the existing one. So, but it's all kind of very much hidden, and there's a marketing message at the top of the trial there. So those are the first two things. What do they compare their new treatment to? What outcomes did they look at? The third question is, are the trials published? Perhaps people can put in the chat here something. So we've got this issue of trials that are sometimes not published, and I'm going to give you an example. This is something called Aldara imicrimod, which is got quite a sort of small range of indications, but one thing they looked at early on with Aldara was whether this is useful for treating molluscum. And there was a small trial, 23 people with molluscum in 2004. Those who had imicrimod, it seemed to, some of them got better, 4 out of 12. Those who didn't, those who had the placebo, it had a lower rate. Okay, so it looked like maybe does something, but absolutely tiny trial, enough to go and do some proper trials. And the company then did 3 randomized controlled trials to see whether imicromod would help clear up molluscum, which of course has very few effective treatments, so it'd be a nice market for them. Those trials were never published. And when I was doing my PhD in around this time in Australia, the dermatologist and immunologist said, "Bob, you've got to use Aldara. It's the best for molluscum. Stick it all over them." Had immune deficient patients and immune competent patients with either very severe or mild molluscum, and you know, we were handing this stuff out like jellies on the basis that someone had heard about this trial, and word had got around the dermatology community. And you still see it used now, actually, in some corners of dermatology as a treatment for molluscum. It doesn't work. It has absolutely no benefit for molluscum, and that was well proven in these trials in 2005. But the trials have never been published. And it was only in a letter and correspondence in the Lancet in 2014 that someone mentioned that the trials had been null. And that triggered a Cochrane systematic review where, to their credit, the company eventually did hand over the data. And that very clearly shows there's no benefit at all to this treatment. So this is a treatment that's used for, you know, the clinical trial results were available in 2005, but it wasn't for 12 years. That the fact that this doesn't work was shown. So that's a classic file drawer effect or publication bias in trials that have an outcome that doesn't suit either the investigators or the funders or both, just don't get out there. And in fact, imicromod's not great for people with molluscum. You get more 40% increased risk of, you know, local reactions, so it stings and burns more than the vehicle. So it's actually quite an unhelpful thing to hand out to patients, which I've certainly have done that quite a bit and regret it now. This is a well-known as an issue across medicine. And can you perhaps put in the chat anyone who knows any solutions? So what do we do about this file drawer effect, about the fact that you get probably only about half of trials get published? And this is a good example from the field of psychiatry, the selective serotonin reuptake inhibitors, Prozac, etc., which were very exciting, again, sort of 20 odd years ago, and lots of trials done. And this report showed the published reports on SSRIs for depression. See, almost every published report shows a positive outcome, only 3 which don't. They then went to the FDA and said, please, can you share all the data? Thanks, somebody putting a comment in the chat. Yeah, please can you share the all the clinical study reports that have been submitted to FDA, even if they haven't been published? And they managed to get them, which is a major achievement. And they found that the reality is that a whole bunch of trials which don't have positive outcomes, they didn't meet their, you know, predefined efficacy outcome. And the picture looks much more mixed, with a whole bunch of trials showing these SSRIs don't do that much, as well as some trials showing supported data. And you'll see that actually some of the ones which in the published report, they look positive, they then shift down into this black zone when you look at the full clinical study report submitted to the regulators. And as someone's put in the chat, thank you, Matt, this is all about just trying to tell the truth and register your trial before you start it. So you've got these clinical trial registries, which should tell you all the trials which have been conducted, even if they haven't actually been reported yet. And so you can get an idea of, you know, if there are 400 trials and registered and only 30 published, that's sort of something that's really unreliable looking at the published ones, because there's a whole bunch of other stuff there which we don't know about. So the solution to that is meant to be registering trials before they start, which is not mandated really in any legal system. So you can still conduct clinical trials without registering them. You might struggle to get them published, you might struggle to get, or published in the top journals, you might struggle to get a license from some regulatory authorities if you haven't registered them. But in general, there's not an absolute thing there. So still a lot of trials are not registered, or they're not registered clearly. It's very unclear what's actually going on there, or they're registered and never reported, which is still an issue, but you don't really know what the results was. It just introduced a lot of uncertainty into the available published literature. The final thing on RCTs, I'm going to stop going on about RCTs in a second, is the data within the trial. So the trial can get reported, but maybe they're not telling you all the results. And you saw that again in the previous slide a little bit with some of the SSRI trials. And this is a typical example from the kind of allergy world where quite a bit of this sort of stuff goes on. This is what, again, is the biggest trial of these types of formula milks conducted. It's called the Genie trial. And you know what they did in this trial is sort of classic. You run your trial, you look at a bunch of outcomes, and then go, yep, that's the one we were looking for. That's the one. Yeah, the one which changed. Yep, that was our main aim. Main aim was that one. And you know, if there's no record, there's no dated record of what they intended before they started the trial. I mean, it's such a temptation. You know, when you do a trial, you look at 50 different measures and 3 of them look great if you put them all together. Well, why? You know, the pressure, especially if you've got commercial pressures as well as, you know, academic and, you know, pressure is immense, really, to twist it and make the data look slightly better than they really are. And so again, that's about trial registration. So you've got to register your trial before you start it and very, very clearly state what your comparisons are. And what your outcome is going to be, and what do you mean by that outcome? You know, state it precisely in terms of time points going to be measured, you know, method of measurement, how are you going to analyze it, and really you need a little bit more than what a trial register. You need a protocol there, and a publicly available state-stamped protocol, which says all these things, and a statistical analysis plan, because again, you can go all the way down, but then you can measure it statistically. You can analyze things in multiple different ways, and you know, what they call p-hacking, or you know, trying to find a result that looks best. So as much transparency as possible, and really the main call now is for people to put the whole data set in the public domain when they do a randomized controlled trial. And there's a good argument for that, because trials involve people giving their time for free. They often involve a lot of public resource, using healthcare facilities or publicly funded academic institutions, to then hide the results from the public and keep them in the drug company drawer and just let out little bits of them. Doesn't feel quite right. So in this Genie trial, which I mentioned, in 2003, this is comparing one type of formula milk to another to see if it prevents eczema. 2003, they published the results in the leading allergy journal, but they amazingly they only published the results on 1,000 out of 2,252 randomized participants. So extraordinary that the journal allowed them to publish, you know, these are our results, and they're showing like 40-something% of participants, and they're not telling you what happened to all the other ones. And you know, Genie, it wasn't registered. There's no public available protocol, etc. So it's really hard to know what the intention of the authors was, you know, from the start. And it's actually, you know, they published a little bit more information a few years later, but it actually took some time for the whole thing to be published. So, and interestingly, you know, Genie is an example of how this can feed into, you know, regulatory activities and patients. This is the, you know, the product studied in Genie and shown to be effective in that sort of subset analysis. And this is actually still marketed in the UK with this claim that it's clinically proven to reduce eczema by over 50%, with a reference to the Genie study. So despite it, you know, very evidently being selective reporting, it's managed to have impact, you know, at the regulatory legal level. So companies are allowed to say this, which is, you know, patently not supported by the intention to treat analysis. So that's enough on trials. So beyond trials, actually things get more influential. So whatever the trial results are, it's actually probably more efficient and cheaper to influence guideline development, maybe systematic review processes for a company, so that you can sort of influence some behavior at a sort of at the level where you know, people don't often look at an individual trial and change behavior. They follow guidelines or systematic reviews or other piece of information. So, and here I've got a couple of tips for you. So when you look at systematic reviews, guidelines, etc., you must look at the acknowledgement section. So this is based on the same sort of field as that Genie trial. This is about whether the product used in the Genie trial prevents babies getting eczema or allergies. And the conclusion of this systematic review in 2010 is in all studies, every single trial that's been conducted, there was a reduced incidence of eczema or atopic manifestations, which is completely different to what the objective Cochrane reviews, etc., have shown, where they haven't shown it in any of the trials. But the explanation for that is in the acknowledgement section. So who are the people who wrote this? They're not at independent academic institutions. They work for a consultancy firm called Exponent Health Sciences Practice. And they've been funded by Nestle, who happen to make that product, to do this work. Okay, so don't spend a lot of time on these sorts of articles. So when you're looking at anything like this, you look at the acknowledgements. What's the context in which you're seeing this evidence? And that could be a company symposium at a conference, or it could be a piece of work in a reputable journal. But you look at the acknowledgement section. If it starts to talk about medical writers and funding by a company that could profit from it, you're just not going to get a clean look at the information from that sort of piece of work. There, it's marketing as much as science. We see this, the former company sort of excellent at doing this. I mean, this is a guideline. So this is a Turkish guideline on milk allergy. Don't read it. Jump straight to the acknowledgement section. So you got a consultancy firm that's got to raise alarm bells. Editorial support from the consultancy firm. The consultancy firm created the patient management algorithm, manage the project. This just doesn't sound like you're going to get clean information. And you can go to their website, and basically they provide your services aimed at supporting the marketing aims of pharmaceutical companies. So that's their job. So you've got a milk allergy guideline with those guys writing it. It's going to quite likely push things in the wrong direction. This is another one, a milk allergy guideline. This one's more open about the funding situation. It's funded by a formula company. There are companies that make money out of these selling products to manage milk allergy, and they've said that they, again, you've got choice healthcare solutions. So consultancy, medical communications, strategic communications, which motivate and inspire behavior change. Right? I mean, it couldn't be more obvious. You've got a company that would profit from increased use of the products, paying a consultancy firm that does marketing solutions. What are you going to get at the end of that? And I'll show you in the next section what you get with that. So look at the acknowledgement section, the context in which you're seeing the work. That also goes for expert opinion. Now, I don't think expert opinion is a great thing. I don't think it's decreasingly important, really, in terms of driving the way we behave. But we are influenced by, you see a big name and they've written a review article or something. Well, okay, that's a nice overview. Just again, be a bit careful, because you can get these nice overviews. Here's an example from the allergy world. It's talking about EpiPens and things like that. This review article, written by a very well-respected academic, was, it sort of came out at the time that a new competitor to EpiPen was being launched. Again, just jump to the acknowledgement section. Sudler medical communications should be starting to sound familiar now. Medical communications, that'll help you with your getting a message across, and it was paid for by the manufacturers of the new competitor to EpiPen, which has just been launched. Okay, and they got pharma consultants. So they got a whole bunch of people kind of, how do we frame this? So this looks rather like something called ghostwriting. So we talked about seeding trials. I also want you to be aware of ghostwriting, and I don't know whether you're aware of ghostwriting already. Ghostwriting, again, was only really been known about in the last 10 years because of legal cases and documents that come out of companies. But again, this is the marketing department. And you must remember that pharma spend 80% of their money on marketing. The majority of what pharma do is about marketing, getting the message out there, and instilling behavior change and the use of their products. So ghostwriting is where the marketing department of the drug company will create some academic articles in order with specific marketing purposes behind them. And they'll write the whole article and then look for a leading academic, to give it some credibility. And they'll, phone up Joe or whoever it is, or Jane, and say, we'd like you to write a piece, but don't worry, we'll do a lot of the legwork. We'll just send it to you for editing and proofing, and we'll pay you a fee for it. And obviously we will acknowledge the help of the writers in the acknowledgement. So it's the same sort of thing. Go to the acknowledgement section. What happened with the HRT is a sort of classic example of ghostwriting. And what happened with this was that Wyeth commissioned a company called Design Write to help them write these reviews and commentaries with specific marketing aims. They wanted to stop people worrying about the breast cancer risk with HRT. They wanted to promote off-label use, for these sorts of things. So helping with some of the conditions of the elderly that might affect that group, and to defend that this was really good for your cardiovascular system. And when I was at medical school, these messages filtered into our Prof of Obs and Gyne's teaching about HRT. And I remember getting really excited about HRT at medical school during the 90s, because I was told that HRT, improves symptoms of the menopause. It kind of corrects a physiological abnormality associated with our increased longevity. And it reduces risk of breast cancer, reduces risk of cardiovascular disease, and reduces fracture risk. And I told that to my family and friends, and indeed a neighbor started taking HRT, and she suffered from a stroke and breast cancer soon afterwards, and is still extremely disabled thanks to her stroke from that advice. Just to sort of try and point out that these things matter. It's all kind of funny in a game and playing with numbers and people manipulating things, but it has real patient consequences. And that's just a sort of personal example, but there are you'll see it in your practice if you start looking for it. That the reality with HRT is it doesn't have any cardiovascular benefits. In fact, it has an increased risk of stroke and increased risk of breast cancer. It does reduce osteoporosis, but it has increased risk of dementia and incontinence. So there's a whole bunch of reasons why you might want to have a detailed discussion and thought about starting HRT. And those are being blindsided by this, ghostwriting, which is making it appear perfect, really. It hasn't got a problem, and it does all sorts of good things to your body. And that's all come out more recently. Again, on final point, the context in which you see the results. So this is we did a trial for Nutricia some years ago, and it was 2018. If you were on their website, you would have seen the description of the results, and it said that in infants at risk of developing allergy, using the new special exciting formula has been proven to reduce risk of eczema and allergy development. But you've got to remember, when you're seeing that, you're looking on the website of the people who sell this stuff, right? It's dressed up as a scientific website, etc., and their commitment to science and rigor, whatever. But look at the actual published data, and you see eczema rates with the old standard formula and the new formula were exactly the same, and there was no change in markers of allergy either. So what was on the website was actually the complete reverse to what had been found in the trial. And we've managed to get them to change what's on their website there, but it just makes the point that the context in which you see things is important. And when you go to conferences, most of the conferences are largely funded by industry, not just the sort of industry symposia, which will have a company name on them, but the conference organizers, the professional bodies are funded by industry. A lot of the key academics will be dependent on industry funding for their research. That changes everything. It influences the information you get there and the robustness and reliability of it. My last point, and then if any of you are still listening, we can have a discussion, is which companies do when they can, which is go straight to patients and bypass us. So they use us a lot as a sort of reliable source of information, where trusted doctors and healthcare institutions are trusted. So if they can influence what comes out of them, then that can be good for them. But where they're allowed to, they go straight to patients. And obviously, drug advertising is quite limited in this country and many. But other things, and I'm going to give you an example here from, this is food. It can be, you can communicate to patients much more easily. And this is back to that topic. I remember I showed you a couple of guidelines, the Turkish one and the Middle Eastern one, around milk allergy. You remember they were funded by, one of them was funded by a formula company, and they were run by consultancy firms. What were they trying to do there? Well, they were trying to do a similar thing to this milk allergy guideline here, which is, and these are guidelines designed to help you understand whether your child has a milk allergy. And again, look at the website here, charity, but the charities, takes funding from the formula industry. Another charity, I don't know what their funding relationship is, the formula industry, education, and formula industry. So already you're saying, well, look, why am I looking at this guideline? The context is all wrong, right? It's not sort of nice, drug and therapeutics bulletin, BNF. It's not like a sort of trusted independent government source. This isn't Cochrane or something. It's got industry, so you've got to be a bit careful. And you look at what they're saying. They're saying, this is when you might have milk allergy. If you have one or more of these symptoms: crying, vomiting, loose poos, red bottom, tummy ache, basically a whole bunch of fairly normal infant symptoms. If you've got one of these, you might have milk allergy. And you'll remember that milk allergy affects about 1% of babies, and any one of these symptoms affects 20% plus of infants. So it's such a sort of, you can see why the formula industry might be like these guidelines, where they basically kind of denormalize a lot of infant behavior and lead to what BMJ would call overdiagnosis and excessive use of products. And in this situation, the product that the companies are trying to push is specialized formula milk, and you see you've got very high rates of specialized formula and increasing rates in this country, which that red line there is the rates you would expect to be if every single milk allergic infant who's receiving formula gets a specialized formula until they're 1. So you have sort of very high. So and it can get this, the relationship between commerce and health can get quite horrific sometimes. I mean, the good example is the opioid epidemic in North America. Where marketing is thought to be largely responsible for the tenfold rise in opioid addiction in that country. And the commonest cause of death in age 50 upwards, in under 50 in many states now is opioid overdose, and a lot of that is related to marketing, using all these tricks that I've talked to you about today, and especially the sort of influence of healthcare professionals, guideline developments, etc. So just to summarize there, so some quick steps to spotting fake signs. When you see a trial, ask, what was the comparator? And if it wasn't an active comparator, well, what does that mean? I mean, how can I try and marry that up with what I normally use? And the people selling the new product, they need to show you a good reason to pay the increased amount for that new product, really. And they should be trying to compare it to existing treatments. Otherwise, I wouldn't just jump on the bandwagon immediately. You have to take your time. What are they measured? What are they reporting as an outcome? Is it an outcome that's going to matter to my patients? Are those all the trials that have been conducted, or are there some other ones which have never been? And you can only find that out by searching the trial registries. And are they telling us all the results from that trial, or are they just telling us the best bits? And again, looking at the trial registry, say, well, this is what they plan to do, and then this is what they're reporting. Is that the same thing? When you read guidelines, systematic reviews, hear expert opinion, or indeed when your patients look for information, what's the context in which that information is being provided, and how much, it doesn't need to have commercial influence. But you always hear this all the time: we couldn't possibly run the conference in this way without support from industry, or we couldn't have the great lunches that we have. You can do it, right? There are really good examples of people running conferences, you know, I mean, in Norway it's illegal, right? You have all the conferences in Norway are you know, commerce free. You have smaller conferences, and they're, you know, less fancy entertainments and simpler meals. You might have smaller numbers of delegates, but you get science, and you don't get a lot of brainwashing. And with these sort of big fancy conferences where people can't, you know, they're so reluctant to lose their dependence on that commercial funding stream. A lot of what's going on there is brainwashing, really. So look at the context in which you're seeing information, and that will help you avoid being misled too frequently. I haven't had time to give you lots of examples, but really this sort of stuff is everywhere. It's everywhere in the science and literature and clinical practice. Do not underestimate. We all think we're immune to this sort of stuff. Companies wouldn't pile so much money into influencing doctors, into the lunches and the you know, travel bursaries and whatever, unless it influenced our practice. It really does. And it can become the sort of main thing that people talk about and worry about and discuss in their MDTs and they talk to their patients about. I've certainly, looking back on my practice, I've many times been intensely discussing things with patients which were marketing messages and nothing else. And I had no idea, and I thought I was doing the best for them, but I was completely doing what some marketing department wanted me to do without really helping my patients, and sometimes doing them a disservice. Don't ignore the setting. We've covered that one at length. And if you're in a position where you're doing well, and companies want to you know, fund you to do things, just consider the effect that has on your credibility and reputation. It'll lead you down a certain path, and it can seem quite exciting for a bit, and you get little bits more money and, you know, profile in a certain way. But yeah, think about it, and think about the effect on patients of what you're doing. And I would encourage people to say no, if you at all can, to industry. I think as a profession we have a responsibility to put our patients' needs at a high level, and try not to let our own you know, desire for extra dosh to push that. Fiona Godley's is our sort of leader in this regard in this country. She's very strong on industry relationships. So have a look at this talk if you're interested in the area. A culture change is what's needed, and that's why I'm here really. Is we do need to recognise that it's a major problem, and that nothing's going to change unless we. So, you know, no one takes money from the tobacco industry now. There's been a major culture change there. Hospitals, universities, individuals, charities, they all used to take money from the tobacco industry, and it's, you know, that's changed. And you'll probably tell me that lots of people are still taking money from the tobacco industry, but I mean, it's not mainstream anymore. And I think we need to treat, you know, pharma, former industry, other people in the same way. There's no need for us to develop these commercial dependencies, and unless we do that, you know, the stakes are quite high. So that you know, you end up with science that's not science. It's just pushing out old misleading messages. You end up with medical education that is brainwashing, either undergraduate or postgraduate. You end up with really significant public health harms potentially. Now, sometimes it just means too many people are taking statins. There's a cost there, some adverse effects, but it's not like a major public health problem. But sometimes you end up with the opioid epidemic, and it's a massive public health issue. And it also feeds into the public's trust of medicine. And you know, we can see with COVID, etc., it's so important that the public are able to trust, you know, their healthcare system, which is there to protect them, and do trust them. And if we, you know, give in to the desire to have, you know, nice lunches and these conflicted relationships, then we mustn't be surprised if our patients stop trusting us and stop, you know, wanting to do the things that we advise us to. So I'm going to stop my rant there. If anyone's still listening, delighted to have any chat or answer questions. Andy, that's great. I think it'd be lovely to see that link, Andy, maybe before the recording stops, of the Cochrane review on e-cigarettes and smoking cessation.
Yeah, Bob, I don't know if you can hear me.
Yeah.
Thanks for a fantastic talk. It really emphasizes important issues that we simply have not come to grips with. it's many, many years since I reached the same conclusion as you, that actually to take any money from anybody into my personal pocket was just simply out of the question in terms of integrity. The e-cigarettes one was a Cochrane review of e-cigarettes, in which they said these are very good. These are better than standard nicotine replacement therapy for smoking cessation, and they're very safe. Well, that latter comment, there's none so blind as those who won't see, and there are plenty of acute reactions. But again, the absolute classic, what they did not look at is the standard. I mean, I'm not an expert in smoking cessation, but pharmacological things like bupropion, varenicline have very good effects. So number one, they didn't compare with that. Number two, a lot of the people who so-called quit smoking actually just stuck with e-cigarettes and just swapped one vice for another. I think, I think your point about conferences is extremely well taken, and maybe with hybrid conferences and online, there will actually be an opportunity for people to rethink what conferences should be like. And those who, like me, go to the European Respiratory Society Congress, you know, there's an exhibition the size of the Albert Hall peddling various things.
Mm.
I wonder if I could get you though to comment on all the distinction between some of the really foul practices you've highlighted and some of the trials. I'm thinking particularly of the trials of the biologicals that have been used for cystic fibrosis, which are funded but rely on Vertex funding, independent investigators, published in reputable journals, but trials that wouldn't have been done because they cost millions of dollars without taking pharma funding.
Yeah, and that's always been thanks, Sandy. That's a very good question. So I think where there's a very obvious problem, and we can act very easily, really, is, you know, medical education, guideline production. You know, there's no role for industry there, really. You know, we don't need them to run our conferences and things, and the professional societies, etc. We just have to be willing to pare down and just feel slightly less important. And so I think that's obvious. I think where it gets, where there's a sort of more nuanced debate is around science, and because you need academic industry collaborations for science. Industry have a very important role in society, you know, making and delivering products and sometimes inventing them, and you know, that's mustn't let all this stop that happening. And I don't think there's an issue personally with an industry funding a trial, but where you run into, so what you need is absolute transparency about the, you know, intentions of the trial, you know, full release of the trial data, and the relationship between the industry and those who are running it and analyzing the data needs to be super clean. And, you know, that's possible. It's not as easy as a NIHR funded trial or something where there's no question. But for certain types of trials, it has to happen. I mean, no one else has got a financial interest in that or got the money to make that happen. So I don't think that all industry trials should stop. But the relationships there need very careful managing. And we had this with that I showed you that Nutritia, you know, the misrepresentation of the trial results from our trial. And when I went back and looked at the contract between the funder and Imperial, the industry lawyers had walked all over us, and we couldn't do anything. We couldn't even get the data set, you know, for the trial that we'd run and had our name all over it. And I think that I mean, there is a real power imbalance there with these big, you know, many billion-dollar corporations and industry. You know, our universities are quite big, but so that all needs extremely careful management. And it's really hard day to day, given the commercial pressures the companies are under, and yeah, so it's tricky, but